have a little about me slide through, as my third slide, so I'll save that for then. So I'm going to be presenting my advanced readings course assignment on perinatal health, and my thesis advisor is Dr. Catherine Baxter. A little land acknowledgement. Brandon University has campuses located on Treaty 1 and Treaty 2 territories. Winnipeg is located on Treaty 1 territory and is the homeland of the Red River Métis, which is where I'm located. Winnipeg is located on the ancestral land of the Anishinaabe, Niniwak, Dakota, and Métis people. For a little bit about me, I graduated from the Winnipeg campus in 2019. I did the program in 4 years. So I went straight out of high school, so I was a little bit um, inexperienced and kind of new to the adult world. In September 2022, I started the master's program and selected the education stream. And I'm currently finishing up my last 2 weeks of maternity leave, but otherwise I work at HSC in Winnipeg. I was previously on the mental health relief team, but since November of 2019, I have been on the inpatient forensic psychiatry. So we do a lot of work with inmates and individuals that need court-ordered assessments. So why I chose perinatal mental health. So originally I had chosen forensic psychiatry as my topic. I was dead set on that from when I applied into the program. However, after having my daughter, I decided that there's not enough perinatal mental health services, and with my own experiences, that I wanted to explore the topic more. So I did forget to mention in the first slide that I did choose blue and kind of the simple blue screen as my color scheme because of the Blue Dot Project, which is a perinatal mental health initiative run in coordination with PSI, Perinatal Support International. And there is a link in my reference slide and attached to the title slide with directly to that site. And this little logo here is theirs. So my personal experience, I had my daughter early at 34.5 weeks in February of 2024. Just spontaneously went into early labor, and so that was a bit nerve-wracking. And then my fiance ended up developing a chronic nerve injury 2 weeks after. And then with my own generalized anxiety disorder experiences, and then having the additional anxieties of going into labor early and being a first-time mom was part of what motivated me to choose perinatal mental health. And for systemic reasons, I noticed a lack of available and accessible resources. Personally, after I was discharged less than 24 hours after having my daughter, and all I was asked were, "Are you feeling sad? Do you think you have the baby blues?" I didn't have really any follow-up or any other questions other than that, and there are no regular practice policies regarding perinatal mental health. So I chose an annotated bibliography versus a literature review. I'm very new to academic research. My BS CPN is my first degree, so I just kind of had I just did the courses that were attached to that program, so I didn't really get much research experience. I hadn't made any final decisions on quite a few of my thesis details, again, referring back to when I had originally decided to do forensics and then changed that within the last year. I wanted to learn more about participant recruitment, data collection, and data analysis strategies. And I wanted to gather more accessible and relevant literature on my topic of choice. For my literature search strategy, I use the spider tool. So it's sample, phenomenon of interest, design, evaluation, and research type. It is better suited for qualitative and mixed method approaches, and it generally elicits more appropriate search data and easier management of results. So I broke down how I used the spider tool for my own research literature strategy. So for my sample that I was going to be searching for was either perinatal healthcare providers or perinatal service users. My phenomenon of interest was experiences of individuals accessing perinatal mental health services. The designs I would be looking at were questionnaires, online surveys, focus groups, randomized control trials, interviews, and online forums. My evaluation part, I was looking at the views, attitudes, opinions, experiences, and feelings. Research type was qualitative and mixed methods. So when I was doing my literature search, I used mostly and or for Boolean operators, just with the different terms that they use for perinatal healthcare providers. A lot of it was postpartum, peripartum. And then I used truncation to widen my search in terms of views, attitudes, opinions, to have different formats of the same words. I used EBSCOhost as it's available through Brandon University, but when I found I was running, was my search results were becoming more and more limited, I used Google Scholar and then checked on EBSCOhost to see if I could verify the peer review status. And I used RefWorks to import and organize my references. I ended up with 14 quantitative articles in my annotated bibliography, but I did not originally include quantitative articles within my literature search strategy because I wasn't confident in the and quantitative data being able to fully represent the participants' personal experiences. And I had developed my literature search strategy with the intention of gathering rich, detailed data about the experiences of perinatal healthcare providers and or perinatal women. So my working thesis question research question is, what are the barriers or challenges experienced by individuals accessing perinatal mental health care in Manitoba, and how can the current state of services be improved? So an overview of my literature reviews. I looked at 60 peer-reviewed academic journal articles total. I split it into two parts, and I ended up organizing them somewhat differently, which was a good learning experience. I ended up with 41 qualitative articles, 14 quantitative articles, and 5 mixed methods. Most of my quantitative articles were in the first half of my literature review, just because I didn't quite narrow down my search quite as much. And my study populations, to break it down, I had 35 articles discussing perinatal women, 20 discussing healthcare provider and or stakeholders experiences, and there were a few articles that fell under both of those categories. And a few articles did not have any specific study population. There was one Maureen looked at. They did, I can't now for the life of me, I won't remember the name, a study. They did phone calls as if they were perinatal women looking for care just to see how different services would follow up. Common topics and phenomena of interest were barriers and challenges and facilitators to accessing care. There were a total of 10 articles. The ones I highlighted here are just ones that stuck out to me and aren't inclusive of all of the articles in my annotated bibliography. So I chose the Buy It articles from 2013 and 2012 because one was from the point of view of healthcare providers and the other one was from the view of perinatal women, which I found interesting that the authors decided to do two different studies. And there were also several articles that discussed how several factors could be viewed as both a barrier and a facilitator. For example, treatment-seeking behaviors. Some women may want treatment, but they might want to rely more, excuse me, on peer support and might be reluctant to take medications. And there is the assumption that perinatal healthcare providers are going to automatically prescribe them a medication, and that might make them more hesitant to seek help. Acceptability of perinatal mental health was another common topic. There were two articles on that, and Selmith et al. Was one of the ones that stuck out to me. And it wasn't necessarily explicitly discussed in a number of articles, but you can kind of draw the conclusion that from the lack of acceptability of perinatal mental health impacts available services and accessing of services. Falmouth discussed the acceptability of perinatal mental health in India, which I know might have limited relevance to Manitoba or Canada in general, but I found it interesting how in a country where mental health may not be as accepted and as openly discussed, that they spoke to different women about their experiences as new mothers. For interventions and programs, there were a total of 15 articles that discussed this topic. Green and Haynes both discussed different psychotherapy techniques for treating perinatal mental health. One was CBT and the other was transactional analysis. Common to both articles were the conclusions that existing therapy and treatment techniques can be altered to be effective treatment options for perinatal mental health. Haynes discussed transactional analysis, a psychotherapy that was not traditionally used to treat perinatal mental illness. The author doesn't discuss the explicit changes to the traditional format, but they do acknowledge that the benefits of transactional analysis in treating perinatal mental illness as experienced by the study participants, that they saw more progress and with the negative symptoms associated with their illness. And Green discussed the use of group CBT in treating perinatal mental illness. Minor changes were made to the delivery of the psychotherapy, um, such as they offered the treatment in a 6-session format to make it more feasible for attendance. And with the randomized control trial that they used, they found that participants who engaged in CBT had their symptoms improved significantly more. I didn't highlight any specific articles on experiences and or beliefs in this slide, just because most of 99% of the articles did discuss experiences and beliefs throughout them, some more than others. So data collection, interviews, focus groups, and surveys were the most commonly used data collection strategies that I came across. Surveys were used in both quantitative and qualitative research studies, as well as some mixed methods. Interviews were used more often than focus groups as they allowed for each participant to privately share their thoughts, beliefs, and experiences. Focus groups were largely used for studies with healthcare practitioners as participants. And randomized control trials were only used for a few select studies, specifically the ones focusing on interventions that I previously discussed. And the most common sampling techniques that I came across were purposive sampling. Well, I'm just going to butcher that pronunciation. Snowball sampling, convenience sampling. I'm leaning towards using interviews as my data collection method. I believe the interviews will help me build therapeutic relationships with participants. With individual experiences being unique, using a semi-structured approach will provide me with some structure, but also give me the flexibility to go with the flow and ask clarifying questions. I found the majority of the studies I came across used non-probability sampling techniques. Several studies used more than one technique due to the lack of initial respondents. Thematic analysis was the most widely used data analysis strategy. Reading through all the articles, I found it interesting to use the different variations that the researchers use, inductive and deductive being two of them. Common study limitations were the small sample sizes, homogeneous samples, sampling biases, and self-reported biases. While the small sample sizes were frequently identified as a limitation for most of the studies in terms of limiting their transferability, less study participants often mean spending more time with the participants that you do have, allowing the researcher to gain a rich, in-depth understanding of experiences. The majority of the studies I came across with small sample sizes had very similar findings, lending to the validity of results. Most of the study limitations seem to be related to participant recruitment techniques, that is non-probability sampling. While unintentional, a number of studies indicated having homogeneous samples. Select studies also identified sampling biases, such as participants with a keen interest in the subject being the only ones to reply and participate in the study. Additionally, with most of the questions requiring participants to remember past situations, there was the concern of inaccurate recall. And self-reporting biases were also included misinterpretations of survey questions. And in a few select studies, they did ask if certain participants had education related to perinatal mental health. However, they did not specify what would constitute perinatal mental health education. Literature review findings and conclusions. I found there was limited Canadian literature. Accessible literature about perinatal mental health is limited in general. Literature about studies in Canada was even much more difficult to find. DeRoche and Hicks both looked at the experiences of Canadian healthcare practitioners when providing perinatal mental health care. Hicks specifically focused on barriers that healthcare providers experienced in providing care. I read articles regarding studies conducted all over the world. Despite the differences in healthcare systems, the barriers and challenges, as well as facilitators experienced by healthcare practitioners and service users, were very similar. The only article I came across that focused on perinatal psychosis was Kobilski. While postpartum psychosis is a less common diagnosis, it can lead to life-altering effects if left untreated. And I thought it was unfortunate that it was rarely touched on in articles. Most of the studies with perinatal women as participants were in the postpartum period, with prenatal mental health being a relatively new study topic. The accessible literature on the subject is even more limited. A lot of women were several months post-birth, and there was limited information on prenatal experiences. Common themes and results. There was a lack of education and training on perinatal mental health for both service users and healthcare providers. I found it interesting that the healthcare providers participating in many of the studies acknowledge that there are significant gaps in their training, but I think this highlights the importance of lessening this gap and the urgency with which it should be addressed. Increased risk of perinatal mental health conditions amongst minoritized ethnicities, including Indigenous people. I was particularly interested in this as due to my own Métis ancestry, as well as the large Indigenous and immigrant population in Manitoba. In my current nursing role, I see the effects of the increased risks experienced by Indigenous people, and I would like my own thesis work to benefit Indigenous people in Manitoba. Psychotherapy can be a valuable intervention if tailored to perinatal mental health. As previously discussed, psychotherapy approaches were acknowledged as effective treatment modalities if adjusted to meet population needs. And dyadic interventions. Irvin and Matas discussed unrelated dyadic interventions that positively impacted their target populations. These authors acknowledged the importance of interventions that considered both the mother and the baby, as well as family and loved ones. Found was interesting as there was a recent article in the news about a woman in Manitoba who had wanted to seek perinatal mental health care, but there was no option for her to have her baby with her while she sought treatment. So that will be a topic I will be looking into more as I continue with my thesis journey. The lack of mandated screening practices. Perinatal mental health screening is not common practice in most countries. As I mentioned earlier in my presentation, I was only asked twice about my mental health after having my daughter, and I wasn't asked any prenatal screening questions. I was admitted to the hospital for several days, and not once did I have any nurses or doctors attend to me for my non-medical needs. My nurses were great, but the perinatal mental health concerns were not acknowledged at all. I remember being quite upset that I was missed my baby shower due to going into labor early, and I wasn't going to be allowed to possible discharge for at least 2 more days. My nurse did her best to comfort me, but given her workload and lack of mental health expertise, it would have been beneficial if I had been given a visit by a mental health professional or social worker. Another common theme was feeling like a bad mother, societal stigma and expectations, as well as social isolation. That there are minimal resources for partners and families and support people. A lot of typically fathers acknowledge that they would like to know how to better support their significant other or experience their own perinatal mental health concerns, being a supportive partner, and they did not have any resources they could access. And that there's another common theme was continuity of care. It was virtually non-existent, similar to mandated screening practices. Sharing relevant medical history would assist pregnancy-related healthcare practitioners with more appropriately treating mothers at risk. Personally, my nurses were not aware that I was taking sertraline prior to being admitted. I was automatically provided with a prenatal vitamin showing the tendency to attend to medical care. However, I had to ask for my sertraline to be ordered. Meanwhile, that should have been clear um, on my med history. More common themes and results was accessibility, that there are significant gaps, especially in rural locations. Some of this lack of accessibility was due to a lack of awareness of services. COVID also impacted accessible services both positively and negatively, with an increased reliance on online services. Online formats were identified as useful, including peer support forums. However, in-person services were also limited due to pandemic restrictions. Trauma-informed, culturally sensitive, and person-centered care studies also identified the need for individualized care that acknowledges all aspects of the patient, and this could include including Indigenous traditional practices. Peer support, McSorley and Moore both discuss the benefits of peer support in helping women with perinatal mental health concerns. McSorley also discussed healthcare practitioner-led resources. The results from Moore's article indicated engagement in peer-led support services ultimately increased the chances women would then engage with healthcare practitioner-based services. A popular theme amongst the articles I read was the impact of COVID-19. The topics that were discussed ranged from the increased prevalence of perinatal mental health concerns that arose during the pandemic, as well as increased reliance on online and telemedicine services and the effects on accessible care. Key gaps and areas of interest for me was the lack of Canadian academic literature, the identification of inadequate education/training, the fact that there's no national strategy and there is a lack of mandated screening practices and inadequate access to resources. Potential research outputs of my advanced readings course would be my thesis study surrounding perinatal mental health care in Manitoba, publishable academic research, presenting research to relevant stakeholders, education and information sessions/tools on perinatal mental health services in Manitoba. Potential research outcomes, improving perinatal mental health education and awareness of perinatal mental health concerns, including both providers and service users, policy and practice changes, including mandated screening practices and healthcare provider education, increased accessible resources, increasing access to current resources, and developing additional resources, as well as documentation supporting the development of a national strategy for perinatal mental health. And that concludes my presentation. The last few slides are all references. If anybody is interested in more information or more details about my annotated bibliography, my email is on the title slide.